I'd now like to welcome our keynote speaker, who is Samantha James from NAVCA. Over to you, please, Sam. Thank you.
Cheers. My name's Sam James. I'm the Health Integration Lead for NAVCA. And today I'm going to share some findings from a report that we published in January on integrated neighbourhood working. But more importantly, what those findings mean in practice and some of the practical things that can be done to support it. So I'm going to briefly introduce NAVCA, our networks, and the voluntary sector before kind of going into some of the key findings from that report. So a little bit more about us. So we're the national membership body for local voluntary sector organisations like Communities First. We have over 180 members across England, covering about 80%, and our members support around 168,000 voluntary and sector community organisations within their locality. And our members play multiple roles, and I suppose key to what we're talking about today is the supporting voluntary sector organisations to start, to grow, to sustain, to provide the things they need to function as organisations, acting as a bridge between the voluntary sector and public sector partners, and then convening local networks and partnerships across communities, so supporting the voluntary sector to connect to each other. So in addition to this work, we also work alongside ICS voluntary sector alliances. So across England, with the currently 42 integrated care systems, most of them have a voluntary sector alliance that works alongside the integrated care boards, acting as a strategic partner, so working with local infrastructure organisations in their areas, with larger voluntary sector partners, and acting as that strategic partner with integrated care boards. And NAVCA hosts Alliance 42, which is a collaboration, a network of all of those organisations, strengthening strengthening the voice nationally for the local voluntary sector and their role within health systems. So before I go on, and I think the next 3 slides, I'm probably telling you a lot of what you already know, and I guess my hope in sharing them is that maybe if you're working with colleagues that haven't got as big a connection to the local voluntary sector, it's just a way to kind of get a sort of shared understanding. So I just wanted to go through a bit of what the voluntary sector is and the ecosystem itself. So when we talk about voluntary sector, non-profit sector, third sector, or VCSE, if you're looking at the VCSE, the word voluntary relates to the governance of the organisation. So it's registered charities with that volunteer board of trustees. And when we speak about the voluntary sector, that's the bit that we need, which I think sometimes with working with health partners, particularly those a bit further away from communities, maybe don't kind of recognise in how the space operates. When we talk about community groups, and I know you use kind of faith within your acronym, but then this is where kind of a lot of faith groups would also kind of sit. So they're what's sometimes called under the radar groups. So they have an income of under £5,000, which means they don't have to register with Companies House or as a social enterprise, with Charities Commission, or as a social enterprise on Companies House. So they're normally formalised, they have bank accounts, but they don't need to be kind of registered. And then social enterprise, we as NAVCA would only include social enterprises that have a legal standing that means that all of their profits go into the community, and that's only about 27% of social enterprises. So in terms of what that makes up of the voluntary sector, so when you look at that whole ecosystem, including those under the radar groups, actually even charities only make up 26% of the sector, and community organisations make up about 68% of it. And looking at the charities element of it, 80% of those have an income of under £100,000. And if you look at that in terms of numbers, so on average, if you're looking at national figures and looking at that per primary care network, you're looking at around potentially about 400 voluntary sector organisations working within a primary care network, with about 100 being charities, but sort of about 250, 270 being those under the radar groups. So I just wanted to kind of emphasise that just on the scale of that ecosystem, and a lot of it is sort of relatively hidden to a lot of health partners. And then sort of moving on to the reason that we've been sort of asked to come here today. So there's obviously a huge amount of energy nationally around neighbourhood health and neighbourhoods more generally. And we'd written a report that was published in January on integrated neighbourhood working. This report brings together insights from across our network to understand how neighbourhood health is actually sort of developing in practice. And it draws on the experience of local infrastructure organisations in our network alongside those alliances perspectives as well. Both of them sit at that interface between the voluntary sector and health partners. And the report, basically what we were kind of asking of our network is what neighbourhood working is actually looking like on the ground. And we took these insights from, I think they were sort of over 18 months. So the majority of sort of last year and as these conversations were emerging at the end of 2024. So through that process, we've been able to identify a number of consistent themes, sort of opportunities and some of the barriers, particularly around partnership working, governance, funding, and how community insights are used within decision-making at all levels of the system. And the report focuses on the role of the voluntary sector in enabling community-led neighbourhood health systems. So not just as delivery partners, but as strategic partners in shaping how those systems, those services, those pathways actually work. So, why this matters, which I'm sure you all kind of know, is that there's the NHS has a clear strategic shift from hospitals to community, with a stronger focus on prevention, population health, and tackling inequalities. And neighbourhood health sits at the centre of that shift. We've got national policy, which increasingly expects services to work in an integrated and place-based ways alongside communities. And while the ambition is really, really clear, the conditions for this delivery are really uneven, nationally, but also locally within systems and different pockets of it. And many systems are still working out what neighbourhood working actually looks like in practice. So although there's a huge opportunity, the realities of these partnerships are really kind of unclear at the moment. So the role of voluntary sector within this space, so local organisations are embedded within the communities. They hold a lot of trusted relationships and understand the really sort of detailed and nuanced context of a lot of this, of the communities that they serve. They often reach people that are least likely to engage with statutory services until kind of later down that line or at crisis point. And because of this, they play a critical role in connecting communities with health systems, and they bring lived experience and community insights into decision-making, and much of that work supports prevention, early intervention, and the social determinants of health. So the voluntary sector isn't just another delivery partner, it acts as that kind of connective tissue in neighbourhood health, linking community services and insights so that the statutory systems can't offer alone. So going on to some of the insights and the key findings from the report, the first one that came through was around defining neighbourhoods. So there was a lot of confusion about what neighbourhoods actually mean in practice and how they'll work. So across the country, there are multiple different neighbourhood initiatives happening, not just in health, but also within local authorities. And the roles and relationships between these aren't always really clear, and they're not clear to a lot of the voluntary sector organisations, all the health staff delivering these services, which means that they're really not clear to the communities that we're trying to serve. And this creates a lot of confusion within the space. And often neighbourhoods are defined, say, around a primary care network footprint and in the delivery of services, but communities don't experience neighbourhood in the same ways, and both of these are fine, but without unpacking this and creating a shared understanding of community working and how that's going to work in your places, partnership risks becoming fragmented with duplicated activity, kind of overlapping priorities, rather than genuinely integrating and collaborating around the communities that you're wanting to serve. The second one was around fragile relationships. So neighbourhood working is fundamentally relational. It depends on trust between organisations, between communities, and different sectors. But partnership remains uneven across neighbourhoods. And in many places, the voluntary sector is engaged quite late often around delivery, rather than shaping those priorities, those services, and building it off the assets that are already in place. And building trust takes time, takes investment, and it takes consistency of relationships, something that is really hard to find in a lot of in the way that we're having to work at the moment. Yet this relational work is kind of often undervalued and under-resourced. And I think there's a quote on here that you can't commission trust, but you can fund the relationships that make that trust possible. And I don't think that's just true of the voluntary sector. I think those roles and that time and headspace is also needed within health partners as well. So the third one is on data and insights. So health systems hold a huge amount of data, but this alone doesn't provide a full picture of what the community need is. And many voluntary sector organisations hold really deep community insights, particularly for groups underrepresented in formal data sets and marginalised from health systems. Yet the community intelligence isn't always embedded in system planning. Embedded in planning. And lived experience is often consulted, but it's then not structurally integrated into that decision-making, into the pathways that exist. And neighbourhood health needs both system data and community insights working together to create a complete picture and support the lasting change that's needed. And then a kind of a point on community and on capacity. So neighbourhood working places high expectations on local partnerships, but investing in the enabling infrastructure doesn't always match those expectations. So many smaller voluntary sector organisations simply don't have the time or resources to engage consistently in multiple conversations at a neighbourhood level. And without the support from local infrastructure organisations, there's a real risk that partnerships become dominated by local partners, by health partners, by other statutory partners, which can unintentionally narrow the diversity of voices that are included. So capacity isn't not just an operational issue. It shapes who's able to participate in neighbourhood planning and collaborative approaches. And then finally, there's just a point around leadership. So neighbourhood working isn't just about coordinating services. It represents a shift towards that population-focused leadership and shared accountability for common outcomes. And that kind of leadership requires diplomacy, trust building, shared power, and the ability to work across sectors and organisations, and that NHS systems and structures and providers can't provide this shift alone. So leaders need to extend beyond the organisations that they normally work with, and recognising the voluntary sector as strategic contributors to prevention, community engagement and system change. And this was echoed in, there's a link in the slides that I think will be shared, and this is echoed in a recent blog by Dr. Duncan Gooch, who's the chair of Confed's PCN network. So I think one of the risks within the work in this space is that neighbourhood health becomes an NHS coordination exercise on improving how services work with each other, but not how systems work with communities. I think the risk then is that communities disengage because partnerships are more transactional than meaningful, that grassroots organisations disappear from a lot of these partnerships because they're not really seeing any real change for the communities that they serve, and that results in systems losing trust and intelligence needed to make the changes that neighbourhood health was set out to achieve. And ultimately that kind of perpetuates a lot of the inequalities and deepens the inequalities that we're already seeing. So what works when partnerships are strong? So despite all these challenges, the network shared lots of examples of where neighbourhood working is working well. And this is partnerships built around trusted community organisations and existing networks, community connectors and neighbourhood hubs embedded within those trusted community settings, that trauma-informed approaches are co-designed with communities, and that social scribing is embedded within local voluntary sector networks and local community networks, and community intelligence is informing health planning and priorities, and crucially the investment in the infrastructure support a lot of these community connections. And what we've seen is the examples show that success rarely comes from creating new structures. It comes from building and developing and maintaining trusted relationships. So I just kind of wanted to point to a bit of an example. And it's kind of detailed in the report. There's some work happening in Cornwall, and they've created a network of community hubs supported by the Voluntary Sector Alliance and the key organisations within Cornwall. And they provide an accessible, non-clinical space within neighbourhoods, providing warm spaces, befriending, practical advice. But the key point to this model was it was built by community partners and volunteers, responding to local need. And over time, as the impact became clear to partners, health partners, the ICB and local government started to invest time to support, to develop, to engage it, and to expand it into other areas that didn't have this resource. And the results are really significant. So 50% of people using the hubs say they would otherwise have accessed healthcare services, often their GP. And alongside this, they also reported improvements in confidence, managing their own health, maintaining their mood, and reducing social isolation. So it's a really strong example of what happens when systems invest in community-led assets and approaches and infrastructure. It improves personal well-being and reduces those pressures on health services. So I think what this example shows is, neighbourhood health works best when it builds on community assets and infrastructure, that trusted organisations reach people earlier, often long before issues escalate to need clinical services, and community-led solutions can reduce access on health services by addressing those wider health and well-being needs. And that infrastructure organisations play a key role in coordinating this, and when systems invest in this, community innovation can really scale. I think what we kind of found through our reports is that what's really, really key to making this work is the intelligence that this kind of connective infrastructure offers. So it surfaces unmet need and emerging issues in communities. It translates community voice and lived experience into system-ready insights, kind of convenes local organisations. It also supports capacity building, so it enables small and hyper-local groups really embedded within their community to have their voice to shape those partnerships. And it's also about shifting that accountability, ensuring that lived experience shapes those decision-making. So the report has 8 policy recommendations, and I won't go through all of them, but we talked about kind of shared understanding of neighbourhood health, for a call for kind of a roadmap on how the voluntary sector is involved in neighbourhood health, being quite deliberate about that. And also, which I haven't sort of touched on, is that the importance of kind of multiple year flexible funding in the investment, the infrastructure to connect communities and organisations in health, alongside commissioning, so that smaller organisations can realistically partake in the partnerships, but also provide the support those communities need to enable that reduced pressure on healthcare services. As well as the points on sort of data and systems, but also aligning a lot of this with other neighbourhood initiatives and local economic development, so other things that are happening in people's communities. Finally, so to finish, neighbourhood health represents a huge opportunity to reshape how health and healthcare systems work with communities, but the real success depends on community power, building community assets, and the infrastructure that supports all of this, helping communities to keep themselves well. And voluntary sector organisations can't just be seen as delivery partners, but recognised as strategic partners, bringing insights, trust, and connections to communities that systems can't do alone, or health can't do alone. And then at the slides you'll be given, there's a link to the resources on what the voluntary sector is. There's also a link to the King's Fund Do With campaign, which is a national network, and there's a really good panel discussion which kind of brings a lot of this to life. And then additional work, there's also a link to the core report, but then there's some work we've been doing with Exeter University on the value of those under the radar groups, so kind of seeing it as the microbiome and the importance of them within integrated health systems. Okay, I'll be around the rest of the day if anyone wants to ask questions or discuss anything.
Thank you very much indeed.